Croup Laryngotracheobronchitis. Key points. Minimize distress to the child, as this can worsen upper airway obstruction. Note, swabbing for COVID-19 or other viruses should not be performed until deemed safe to do so by a senior clinician. Consider early transfer and involvement of senior staff if concerns regarding worsening upper airway obstruction. For severe and life-threatening croup, use nebulized adrenaline. Less severe cases can be managed with corticosteroids alone. Background. Croup is inflammation of the upper airway, larynx and trachea, usually triggered by a virus. Occurs generally between the ages of 6 months and 6 years. Often worse at night. Blank. Blank. Assessment. Children with croup should have minimal examination so as not to upset them further. Throat examination is rarely required. Examination. Barking cough. Inspiratory stridor. Hoarse voice. May have associated widespread wheeze. Increased work of breathing. May have fever, but no signs of toxicity. Risk factors for severe croup include pre-existing narrowing of upper airways, previous admissions with obstruction, previous admissions with severe croup, young age, uncommon and LT 6 months old, rare and LT 3 months of age. Consider alternative diagnosis and causes of upper airway obstruction. Assessment of severity. Mild. Behavior, normal. Stridor asterisk. No stridor, or only when active. Or upset. Respiratory rate, normal. Accessory muscle use, none or minimal. Moderate. Behavior, intermittent mild agitation. Stridor, intermittent stridor at rest. Respiratory rate, increased respiratory rate. Accessory muscle use, moderate chest wall. Retraction, severe. Behavior, increasing agitation, drowsiness. Stridor, persistent stridor at rest. Respiratory rate, marked increase or decrease. Access, use. Marked chest wall retraction. Oxygen. Saturations. Hypoxia is a late sign which indicates life-threatening croup. Asterisk loudness of stridor is not a good indicator of severity of obstruction. Soft stridor in the presence of worsening clinical picture may be a sign of imminent airway obstruction. It is not necessary to measure oxygen saturations in children with mild to moderate croup. Management. Investigations. No investigations are needed in croup, including nasopharyngeal ASPI rate, X-rays, and blood tests, and they may cause distress to the child and worsening of symptoms. Treatment. Minimal handling. To avoid worsening symptoms, limited examination. Keep children with carers to reduce distress. Children will adopt a position of comfort that minimizes airway obstruction. Do not change this. Treat mild croup with steroids alone. Barking cough with no other symptoms does not always require steroids. Moderate croup is usually managed with steroids alone. Consider adrenaline if persistent or worsening symptoms. Severe croup requires nebulized adrenaline and steroids. C. Flowchart. Supplemental oxygen is not usually required. If needed, treat for severe upper airway obstruction. Defer intravenous. 4. Access. Consider a longer period of observation than 4 hours for a child who presents overnight. Lives far from medical care. Presence with stridor more than once during the same illness. Has risk factors for severe croup. Asterisk consider nebulized budesonide 2 mg if oral corticosteroids not tolerated. Consider consultation with local pediatric team when severe airway obstruction present. Child has risk factors or an atypical presentation. Child and LT 3 months of age. No improvement with nebulized adrenaline. Consider transfer when no improvement following nebulized adrenaline. Child requiring repeated doses of nebulized adrenaline. Child requiring care above the level of comfort of the local hospital. Consider discharge when stridor free at rest. N. Minimum of 4 hours post nebulized adrenaline, if this has been required. Or 30 minutes post dose of oral steroids, and adrenaline not required. Parents should be advised to seek medical attention if recurrence of stridor at rest despite having received oral steroids. Additional notes. Antibiotics have no role in uncomplicated croup as it has a viral etiology. Antitussives such as codeine have no proven effect on the course or severity of croup, and may cause respiratory depression and increase sedation. Humidified air has not been proven to change the severity of croup. Heliox has not been shown to be better than nebulized adrenaline in severe croup.